community health. Once again, trying to educate you on health topics that may be pertinent to you or me. And February is Thyroid Awareness Month. We're focusing on the thyroid this show and this month, and we're going to talk a little bit about the thyroid. And I brought an endocrine specialist because the thyroid is part of the endocrine system. We're going to learn a little bit about that. And I brought an endocrine specialist, an endocrine surgeon, because, you know, I'm a little preferential with surgeons since I'm a surgeon myself. But we brought Dr. Neeta Erinjeri from Miami Cancer Institute. She's here with us today. And we're going to talk about the thyroid, diseases of the thyroid, and of course, we're going to talk about thyroid surgery as well. So, Neeta, thank you for coming. Welcome.
Well, thank you so much for having me. It's such a pleasure to be here.
All righty. Well, tell us a little bit about yourself. Tell me a little bit about where you're from and what you do.
Sure. So my name is Neeta Erinjeri. I did my medical training in Michigan. I grew up in Michigan and I did my training at Michigan State. And then I moved to Connecticut to do my general surgery residency at Yale University. And I stayed there actually to do an additional fellowship training for endocrine surgery. So I just kind of focused all of that training down into endocrine surgery. So I operate now mainly on the thyroid, the parathyroid glands, and the adrenal glands.
Wow. So I see you like almost every day at the hospital, and I didn't know you were a Spartan.
I am,
My
yes.
dad was a Spartan.
Okay.
So it's like my second favorite football team.
Go
and of
Green.
Course, yeah. My dad, of course, he went in the 60s to Michigan State. So yeah, I'm preferential. Of course, I'm a Hurricane, but if not the Hurricanes, we root for the Spartans for sure.
There we go. Excellent.
All right. So we're going to talk about the thyroid gland. Why don't you tell us what the thyroid gland is?
Sure. So the thyroid gland is something that I think everyone has at least some general idea of. It's something that you hear about a lot, but this is a gland. It's shaped like a butterfly. It's kind of what I tell all my patients. It's shaped like a butterfly that sits in the front of your neck. And based on stimulation or hormones that are sent from the brain, it produces hormones that then go to the rest of your body and control a lot of functions. But how we think about it basically is that it affects our metabolism a lot. It affects kind of your energy and how you're functioning in that way. And that feedback basically goes from the thyroid back to the brain, and these hormones work like that. They affect each other and how each are produced.
And so what type of problems will people have of their thyroid? What are some of the common conditions?
So the most common issue, especially in the United States, is actually low thyroid function. And what happens through a myriad of different reasons is the thyroid gland stops producing sufficient levels of thyroid hormone. And that is for people who say they have thyroid or they have thyroid problems and they have to take thyroid hormone supplementation is generally from that. And the most common form of that is something called Hashimoto's thyroiditis, which basically over time, your body produces antibodies that affect the cells within the thyroid gland itself. And over time, because of that exposure, the thyroid gland becomes less and less and less productive.
So the most common condition is low thyroid, the hypothyroid. There's also hyperthyroid, right? Where you can be really, your thyroid is out of control.
Correct. Yeah. So there are a couple of different ways in which that happens as well. Sometimes it is a thyroid nodule, which we'll talk a lot more about. But in general, a thyroid nodule is an overgrowth of cells. And if those cells are productive cells, what can happen is that nodule itself can just produce hormone independently of those signals that I was talking about, independent from the regulation of the rest of the body, overproduce thyroid hormone and put you in a hyperthyroid or overactive thyroid state. Or there can be other conditions, something like Graves' disease, where you have an antibody formed in your body that works against the thyroid gland and stimulates thyroid growth. It's not really working against it, but in the grand scheme of things, it does, because it causes your body to produce way too much thyroid hormone, which untreated can cause a lot of other problems because of how the thyroid gland affects every other cell in your body.
Yeah, and I think that what most people are worried about is what you mentioned already, which is thyroid nodules. So we talked about the thyroid being too high, over functioning, thyroid low, hypothyroid. What about thyroid nodules? Who gets a thyroid nodule, and is it concerning? And I have to rush and get my thyroid out if I have a thyroid nodule?
So first of all, thyroid nodules are extraordinarily common, and actually it becomes more and more common as we get older. But looking at overall population studies, we can see that as we get older, probably around 50% of people actually have thyroid nodules. The vast majority of these, greater than 90% of these, are completely benign and they don't cause any problems, and you actually don't need to have surgery to have it removed or have any treatment. But once we find them, when we know that they're there, they have to be formally evaluated, and so you know whether it's fine, because there are those nodules that are either cancer, or they have suspicious cells, or they're overactive, or they're causing other issues, and that's when we have to be worried about it. Thyroid nodules, I said, more common as we get older. They're also significantly more common in women compared to men, and they don't actually know exactly why that is, in that we assume that because of the hormonal changes that happen in women on a monthly basis, that has an effect on the thyroid gland, but actually I haven't found like a specific thing that we can change that would decrease that. There are other exposures that you can have that may increase your risk of having thyroid issues. Specifically for thyroid cancer, what we worry about exposure wise is radiation exposure at a young age. When you're developing, it's less common to have that effect as we get older, but it still is a risk.
Yeah, the radiation is less detrimental to the patient the older you are. The young kids who get radiation is more dangerous.
Exactly.
So, there's a million people watching us out there, and they want to know, how do I know I have a thyroid nodule? Now, everybody's like touching their neck. I'm not worried because you said it's more common in women, so I'm not that worried. But how do you know if you have a nodule?
So I will say, you can have symptoms from thyroid nodules, and some of the symptoms that they can cause, if they are symptomatic, although most are not, but symptoms are what people really look for. Depending on where they are, it can cause difficulty swallowing. It can cause changes in your voice, a sensation of just basically a pressure sensation in the front of your neck. People sometimes have difficulty swallowing certain types of food, such as like dry, crusty bread is hard to go down. Liquids, softer foods go down easier. Those are really issues. These symptoms really come in with nodules that are very, very far in the back, or when they get very large. And really, when they get very large, they can cause more problems, such as putting pressure on your trachea, your airway. People can, when they're very large, sometimes have those sort of symptoms. But the vast majority of thyroid nodules are actually asymptomatic, and they are found by your primary care doctor when they're doing an exam. Part of the physical exam, when you see your primary doctor, is they're pushing on your neck and you're trying to figure out what they're doing because it feels like someone's trying to choke you. That's exactly what they're doing. They're trying to feel that small nodule inside the thyroid. And there are a lot of muscles in the front of our neck that sit on top of the thyroid gland. So you have to really push hard to get that. Or they're seen incidentally on imaging that's done for something else. So people will have an ultrasound of the carotid arteries because they're worried about stenosis in the carotid arteries. Well, they happen to see a nodule in the thyroid gland, or they have a CT scan for some other reason. We find them in these incidental ways as commonly as we find them, or actually probably more commonly than we find them, because people are actually having symptoms.
But I want that blood test to find a thyroid, like the PSA, the prostate is there a blood test I can do to see if I have a nodule or if I have thyroid cancer?
No, actually there is not. No.
Right.
So they do blood tests to check your thyroid hormone levels to see how your thyroid is behaving. Is it producing enough hormone? And they look at both what is being produced by the thyroid, as well as that feedback mechanism for the thyroid stimulating hormone, which comes from your brain, to see basically, is your body in a good balance? And that is something that is done if there is a concern about your overall thyroid function. So patients who come in with, concerns about being very fatigued or tired, gaining weight, all those sort of things that you associate with thyroid, they'll check a thyroid hormone at that time, but it doesn't indicate whether or not you have nodules or thyroid cancer.
Okay, so I go to the primary doctor, he chokes me, he finds out I have a nodule. I know already, because I've learned from you, that 90% it's going to be nothing, right? But how do I make sure? What are the next steps? Do you have to have that thyroid out now because you have a nodule? What do you do now? Right.
So when a thyroid nodule is detected, especially like detected on physical exam, but really whichever way, it's the first step, first of all, is yes, a thorough exam. So if it was not found by your physician, that's what you need. You need a thyroid ultrasound. ultrasound, we have like so many really, really excellent imaging technology, and everyone thinks I need a CT scan, I need a PET scan, I need an MRI. But really, for the thyroid, the best way to evaluate the thyroid gland is an ultrasound, a good neck ultrasound to look at the thyroid gland, and then thyroid function tests to see how is your thyroid functioning. Because we use a combination of those three things: the physical exam, the ultrasound characteristics, looking both at the size and the really details that they can see on ultrasound, and your thyroid function tests to determine what needs to be done. What are the next steps that need to happen in the evaluation of that thyroid nodule? Because, yeah, not everybody needs a surgery following that. So dependent, if your thyroid function is normal and on physical exam they feel the nodule and there's nothing else of concern, then they would use those ultrasound characteristics to determine basically whether you need a biopsy or not, because it will be the biopsy that determines then if we're worried about cancer, and if we're worried about cancer, if we need to have surgery. If the thyroid function is abnormal, there are a couple of other things. So we talked about hyperthyroid, meaning overactive thyroid. So that would change how we would approach it from a surgical standpoint, in that hyperactive, overactive thyroid nodules are very, very, very unlikely to be a cancer. So we don't go down the biopsy route for those. And for something like Graves' disease, where the entire thyroid gland is being affected and overactive, again, we're not as worried about thyroid cancer. But you'd have to do specific tests in those instances, different sorts of imaging studies in those instances, to make that determination about what you're dealing with if it's overactive. If it's underactive, we still do proceed with the biopsies. It would just, again, based on the ultrasound characteristics, and but you may need to take a thyroid supplement, thyroid hormone supplement, if your levels are really underactive.
Okay. So we talked about the ultrasound. You get the ultrasound, you look at the characteristics, may or may not need a biopsy if it's suspicious. Now, I remember from med school and other things, the nuclear medicine test, and you're going to tell us what a cold nodule is. But I always remember that was a bad sign if you had a cold nodule. So what about a nuclear test? In simple terms, tell our guests what a nuclear test is. And I try to explain a nuclear test for like the gallbladder, and it's kind of difficult. But does everybody need a nuclear test?
Okay, so first of all, now we have found that not everybody does need a nuclear test. It's really when we see abnormalities in the thyroid function that we go down that route of doing a nuclear test, because what we're looking for is a hot nodule versus a cold nodule. We used to do them a lot more commonly, and it's become less common now because we found it's a little less useful now. There's not as much applicable information if you have normal thyroid function. But what the nuclear medicine test is in regards to the thyroid is the thyroid gland, how it makes its hormone is with iodine. And we, especially here in the US, there's iodine in table salt. So we have plenty of iodine in our diet. So our thyroid glands have that building block that it needs to make the thyroid hormone. And the good thing about it is that the thyroid cells are really the only cells in your body that absorb that iodine. So what we have found from a nuclear medicine standpoint is you can take iodine and attach a radioactive particle to it. You can take that iodine then, and it will be absorbed by the active cells in the thyroid gland. So a hot nodule would be an area where that part of the thyroid gland is absorbing all of the iodine, and it will show up like a bright spot, and the rest of the thyroid gland won't absorb as much because that nodule is basically doing all the work. That's a hot nodule. That's an overactive nodule. That the risk of cancer is extraordinarily low. A cold nodule, though, as you mentioned, is concerning. And what that means is that shows up that the rest of the thyroid gland is absorbing the iodine and functioning normally. But that nodule in that area, if it's cold, it means that the iodine was not absorbed in that spot. And that tells us that that cluster of cells there forming that nodule is not absorbing iodine normally, so it's not functioning normally, and the risk of cancer in that instance is a bit higher. So those would be concerning and would warrant biopsy then if we see a cold nodule like that. But if they have an overall normal thyroid function, we wouldn't necessarily be doing that test.
All right. So of course, what we're really worried about here is cancer. And, that's the diagnosis nobody ever wants to have. And so we have a suspicious nodule. We have a cold nodule, and that patient needs a biopsy. How is that biopsy done?
So biopsies for the thyroid gland are done with what we call fine needle aspiration. So generally with ultrasound guidance, similarly, they just put an ultrasound probe on, and with a very, very, very fine needle, so small needle, it might look long, but it's thin. They go and they just pull a few cells out from that nodule. They don't take a chunk of tissue or anything like that. It's just they pull a few cells out, and we look at those cells under the microscope. And then we have kind of an array of findings that we can have based on the cells that we're looking at. And those findings in those cells, the characteristics that we see in those cells, they can say this looks like a benign nodule. Great. We'll have to do additional follow-up based on that. It can look like a cancer. Okay, this is what we need to do because it looks like a cancer, and there's different types of cancer, which we'll talk about. And then there's an array in between, which I really always try and emphasize to my patients that we may not have a black and white answer. We may have something in between, and there are different basically risks of cancer based on the characteristics that they see. Because they're not getting a chunk of tissue, they're just getting cells. Based on how atypical and in what way those cells look, we'll say, okay, based on this, you have what we call a follicular neoplasm. That doesn't mean a cancer. We just don't know. And the risk of cancer is approximately 30%. And so it can be 15%. Or this looks like a cancer, but not enough to make the diagnosis. So the risk is maybe around 75%. But then I, as a surgeon or the medical endocrinologist who is doing a lot of this initial evaluation, will say, okay, based on this, we recommend this treatment. And that it's those, when we start seeing those abnormal findings on the biopsy, that we're talking about thyroid surgery. It's not the only reason we do thyroid surgery. I do a lot of benign surgery as well for different reasons. But of course, looking at cancer, which is what people are the most worried about, those are the reasons when we see those abnormal cells under the microscope that we have that conversation about surgery, and then how much surgery, because it varies dependent on what it looks like.
All right. So we do a biopsy, turns out to be cancer. How many types of cancer are there in the thyroid?
There's many, but 4 major types of cancer that we talk about. The most common is papillary thyroid cancer. That's the vast majority of thyroid cancers. And what is good, if you can consider anything good about cancer, is that papillary thyroid cancer is extraordinarily treatable. It has a good prognosis. And we're talking a 5-year survival of over 98%. So people with appropriate treatment tend to do very, very well with papillary thyroid cancer. The other types of thyroid cancer, we have medullary, follicular, anaplastic. These, and then there are different subtypes, and you can have other things that go to the thyroid, but talking main types, they get increasingly more aggressive with worse prognosis, but they're extraordinarily more rare compared to papillary.
Yeah, I remember from med school, like if you had to choose one cancer to have, it's papillary thyroid cancer, right? I mean,
or lymphoma, I guess.
Right, I guess. But okay, so I'm diagnosed with thyroid cancer. Do I need surgery? Does everybody need surgery with thyroid cancer?
The easiest way to say that is yes. There are rare circumstances where surgery is not part of the treatment plan, but the vast majority, the way to address it is yes, because we can't go into every individual detail. But the mainstay of treatment for most of these thyroid cancers is surgery. Surgery to remove part or all of the thyroid, depending on what sort of cancer we're dealing with and the size and the other characteristics. And sometimes that's with the surrounding lymph nodes, sometimes it's without. But surgery is, especially for papillary surgery, is the first part of treatment. And we're generally not talking about having to do chemotherapy or radiation therapy after it's surgery, and then long-term management and follow-up to make sure that there's no recurrence.
So let's talk about surgery. Of course, you're a surgeon and I'm a surgeon, so we love to talk about surgery. So, and I know there are different ways to remove the thyroid. Of course, most of our audience will be familiar with the cut that you get across your neck, the low cut around the neck. So let's talk about, those different options. And you and I have even talked in the hallways about, in the East, how they remove the thyroid. So tell our guests about the different options and different ways to remove that gland in your neck.
Sure. So yeah, the most common way that surgery is done for the thyroid gland is through an incision that goes kind of at the base of your neck. And everyone has these natural lines that occur with time on the front of our neck. So we curve it along that line. And if you look at old photos, it used to be, a cut like fully across the neck. It's not like that anymore. Now we can do a nice small incision right in the front of the neck and take the thyroid out, either half or whole, depending on that We get into those longer incisions when we have a more aggressive cancer that's spread to lymph nodes. That's sort of a different situation, even as far as approach goes. But that's the most common approach is like that through the neck. As you mentioned, then they have developed additional ways to get to the thyroid to try and avoid a scar here. Now, I have to say, of course, I'm a thyroid surgeon. The scar here heals extraordinarily well. It's really not as noticeable, but it can be a concern. And so they have developed ways to take the thyroid out from the axilla, so basically like going through your armpit to get to the thyroid. They go through areolar, so they go in basically through the breast to get up to the thyroid. They can go from behind the ear to get to the thyroid, and each of these really the only benefit, because it ends up being, in order to get to the neck from any of these locations, you have to come through a lot more tissue to get here versus cutting down directly over it. But the benefit is cosmetic. So patients who really, really feel adamantly against having an incision on the front of the neck, this is a technique that has been used. And from that, then they have now developed a technique that goes through the mouth. Actually, in the lower lip, incisions are made in the lower lip, and kind of you go over the mandible, so the jawbone, to get to the thyroid gland, and the thyroid gland can be removed that way. Again, all of these come with their own risks that are in addition to the risks of a normal thyroidectomy, but are done basically for cosmetic reasons. And here at Baptist, we have done the transoral, so through the lip. We don't do the other routes because of the risk profile in those approaches we find to be too high. But the risk profile for the surgery through the lower lip is lesser. Just because it is a little bit more direct from that standpoint, and the inside of the mouth heals very well. But it's really only a select patient population for which this is even a consideration. And unfortunately, for especially larger cancers and things like that, it's just not the compromise that you have to do it in that way is not worth the outcome from our standpoint. When we're doing thyroid surgery, any surgery really, the number one thing is patient safety, right? So we want patient safety, we want to get a cure, and then we do want a cosmetic result. We want it, maybe not as much as the patients, but
Right.
but very strongly, and it's something that we worry about as well. But you have to, it does have to come third in that situation, especially when you're dealing with cancer.
And so what about the recovery? So you have thyroid surgery, whether it be you guys do it at the neck or you guys do it through the mouth. What type of recovery should a patient expect with that?
So most patients, depending on how much of the thyroid gland is removed, if we take out half, some patients go home the same day, but most patients stay overnight in the hospital, one night, go home the following morning. So you're still talking about, usually less than 24 hours in the hospital, eating regular food the same day as surgery, talking up and out of bed. People have, of course, pain in the neck as well as in their throat, just with swallowing, which is pretty normal after surgery. It's usually, though, pretty mild. Patient needs pain medication for 2 to 3 days, and most people will take about a week or so kind of at home, taking it easy, although we encourage them pretty aggressively to be up and active and mobile, and even with moving their head, moving their neck, stretching these muscles out, because it's important. Healing, you don't want to let everything get stiff, especially the neck has a full range of motion beforehand. Our goal is that it stays that way after, because we don't want to deal with muscle stiffness, muscle spasms, because it can make the whole recovery process a little worse for the patient.
Yeah, the other day I was surprised how fast people recover. You guys did one of my nurse practitioners, and I called her in the afternoon to see how she had done from surgery, and she, oh great, this and that, and I said, where are you? She goes, I'm home.
Yeah.
I said, what? And then she has 2 small kids. I thought she would like stay in the hospital for vacation, but she definitely went home. So, do thyroid surgery. Now, sometimes people need lymph nodes removed as well, and it's more radical. Why is that?
Yeah, so we approach the lymph nodes in the thyroid based on kind of what we're worried about. So with thyroid cancer, what we know is very clearly kind of how thyroid cancer spreads. So thyroid cancer starts in the thyroid gland, and the first place, if it does spread out of the thyroid gland, is to the lymph nodes basically right around and underneath the thyroid gland in what we call the central neck. And then if it spreads from there, it generally goes to the lymph nodes in the lateral neck. And, on each side, depending on where the primary tumor is, it's most likely to be on the same side. From there is when it starts, where we see that it starts to spread then to other parts of the body. So when we have a patient with thyroid cancer before surgery, we do make sure they have had an ultrasound evaluation of these lymph nodes in the central neck as well as in the lateral neck, to make sure that there's no evidence of spread. If there is evidence of spread or concern for spread, we would biopsy those lymph nodes ahead of time. And if there's evidence of thyroid cancer that has spread to a lateral neck lymph node, then the surgery becomes surgery to remove the thyroid gland in total, the lymph nodes that sit right underneath the thyroid gland or around the thyroid gland in the central neck, because we know if we got there, it's because it came through these lymph nodes here. And then that side of the neck, we clear out, we do what's called a modified radical neck dissection to remove the lymph nodes, basically in the areas that are common for thyroid cancer to spread. So along that, your sternocleidomastoid, which is this muscle that extends from kind of across the side of your neck that people see, makes that contour of your neck, the lymph nodes in around and deep to that muscle. That is a bigger surgery because we're dealing with a more aggressive cancer in that instance. If we don't have evidence that it has spread there, but we are dealing with a thyroid cancer, then during the operation, even though we have looked at these lymph nodes by ultrasound beforehand, even if it didn't show anything during the operation, I will then examine those again with my own, obviously I'm not with microscope because my eyes are not microscopes, but to see if anything looks or feels abnormal in that moment, and it may change how we approach it at that time. You can see spread there even that you didn't know about ahead of time, and it may change how you manage the patient. So that is why I take in all patients who have biopsy-proven cancer, even if the lymph node mapping or the ultrasound has not shown anything, that we evaluate those lymph nodes in the moment of surgery to make sure that it doesn't change how we want to approach it.
Well, I mean, the good news is that 90% of people with a nodule will not have cancer.
Yes.
And of course, if they do, surgery seems to be quite fast recovery. We've already heard the outcomes are great in the majority of people if you have papillary thyroid cancer. Now, of course, surgery comes with risks. What are the common risks that we may see somebody have with surgery?
Sure. So risks in general are, anytime you have surgery, there are risks. And what we worry about the most are bleeding, infection, injury to the nerve that travels behind the thyroid gland that controls your vocal cord movement. That's what we worry about the most. And then your parathyroid glands, because next to the thyroid gland are teeny tiny glands that control your calcium level. And we have to protect those during surgery. Those are the four most common things that we worry about during this operation. But realistically, the risk of that happening is below 1%. But we talk about them at length kind of with the patients and do everything during surgery to avoid those issues. And as an endocrine surgeon, since the majority of my operations are right in this area, either for thyroid or parathyroid, it's what we are dealing with in the operating room every day. So that the kind of repetitiveness of it helps the patients, I think, because you just are seeing the same thing.
No, what surprises me is, I've been out here 25 years at Baptist, and there was a time period I used to do a few thyroids a year, and now we have surgeons that they spend their life, on a couple organs, and the specialization and the expertise that you develop for these. I mean, no doubt. I always tell people, you're better off, having surgery with somebody who's doing that day in and day out. If I'm doing 400 of these operations, I do 400, let's say, bariatric procedures a year, that's better than somebody who's dabbling and doing a few of them. So we definitely appreciate your expertise and explaining everything to us today. We've learned about the thyroid and where it is, first of all, that the majority of people will not have anything bad. Even if you find a nodule, let your primary doctor choke you a little bit and see if you have a nodule. And then if you have cancer, of course, surgery is somewhere along the way going to be needed, and surgery is safe. And of course, I think probably, if you need thyroid surgery, you need to ask your thyroid surgeon, how many a year do you do, so that you have a safe outcome. So, we want to thank you for coming. Any final words of advice or anything that you would tell our guests about the thyroid that they should remember as they recall this show?
Yeah. So thyroid nodules, I think the biggest thing is that they are common. And if you're diagnosed with them, go through with the workup, but just kind of take peace in the fact that most of them are not as bad as you were worried about. But we have to be careful.
Great. Well, thank you, Neeta. Thank you, Neeta, again for being with us in another great show at Miami Community Health, learning about the health topics. And we'll be back with you on our next show and another interesting topic.